So if the problem is that the tumors don't present antigen, you could also just bypass class 1 by using a T-cell engager. And that's been the strategy with tarlatamab and similar drugs. These are drugs, bispecific T-cell engagers, so they engage the T-cell with an anti-CD3 binding domain, and then they engage the tumor with a tumor-specific binding domain, in these cases, anti-DLL3, which is expressed on the tumor. All of these molecules are in clinical development. All of them are structurally very different, but functionally similar. That is, they have a CD3 binding domain, a DLL3 domain, and the goal is to bring the T cell in proximity with the cancer cell. You activate the T cell, you kill the tumor cell, you inflame the tumor, and you get responses. And of course, tarlatamab has shown substantial efficacy. I'm only going to show one slide from the Delphi 304 trial that I was privileged to help lead, but this was an international study, phase 3, 509 patients, randomizing patients second line to tarlatamab, the T-cell engager, versus dealer's choice chemotherapy, topotecan, lurbinectedin, where it's available, and amrubicin in Japan. And what you can see here is there's a clear benefit in both progression-free survival and overall survival. This was the first interim analysis actually read out as strongly positive for this trial with a hazard ratio of 0.6. I have to say it'll be really interesting to follow these curves out. Median follow-up here is only 11 months. So we're actually early days. We'll see how the tails of these curves really look. But the progression-free survival curve has a tail, and the tail is off the ground, and that gives me real hope. With other tarlatamab trials, as you probably know, the longer we follow them, the better the data starts to look. So if it works in the second line, can you bring it into maintenance? The answer is yes. So these data were presented at World Lung. I think really exciting. These have now been published in Lancet Oncology. These are data that, to me, look really striking. Substantially better outcomes than what we've seen in prior cohorts of patients with small cell lung cancer in the maintenance setting. Overall survival in the maintenance here tracking out over 2 years. These are small trials. We need follow-up data. The phase 3s are ongoing, but I think this looks really, really promising. You could argue that the curve shouldn't start at 100% here because this is maintenance, so patients have had to get through chemo, immunotherapy to get on this, but there was subsequent data presented at ESMO bringing tarlatamab all the way up into first line with chemo immunotherapy, and these data also look really striking to me. You know, with the data that I showed you with chemoimmunotherapy at the beginning, the median overall survival was about 13 months. Look at the survival curve here. 80% of the patients are alive at 1 year. Again, underpowered study, phase 2 data, but totally different looking curves than what we've seen before. And this is super exciting, I think, for patients with small cell lung cancer. The other class of drugs beyond T-cell engagers that I think has shown super promising data in the space of small cell lung cancer has been the antibody-drug conjugates. The first out of the box, of course, was Rova-T, anti-DLL3, which unfortunately was not successful because of a really toxic warhead, but there has been subsequent drug development. I think the last two targets, CD276, which is B7H3, and SEZ6 look really, really promising. And radioconjugates are behind in terms of clinical development, but I think are really promising and really interesting to our group and others. These are data that we published earlier this year in the JCO. It's actually in press in JCO. This is IDXD, so this is anti-B7H3 antibody-drug conjugate from Daiichi Sankyo, now being co-developed with Merck. Really nice data. You see this waterfall plot that we have not seen data like this for small cell lung cancer previously. In the second line setting, response rate of 56%. These drugs are active in the CNS. We see essentially equivalent activity in the brain as we see systemically. I think really exciting data. These drugs have toxicity. You know, we need to watch for ILD when we give these drugs. They're very potent cytotoxics, but really, really active. And I think we have not seen this level of activity with any chemotherapy agent in recurrent small cell lung cancer. The other antibody-drug conjugate that I think has data that's fairly mature, not quite as mature as IDXD, is the AbbVie-706 data. Very similar outcome in terms of progression-free survival and OS to the IDXD. Even higher response rate in the second-line setting at appropriate doses, with responses that are in the 70 to 80% response range. Really, really impressive drug, and I think has a great future. Radiotherapeutic conjugates, I think, are really interesting as well. And our research group at Sloan Kettering, some of whom are pictured here, have been really interested in developing anti-DLL3 radioconjugates for both imaging as PET reagents and as therapy. This has been going on both in the laboratories with graduate students, postdocs, and actually in the clinic. These are clinical data. We took the AbbVie antibody that was used in Rova-T, and instead of using it as an antibody-drug conjugate, we used it as a radioconjugate with zirconium for PET imaging. And you can see on the left a patient with small cell lung cancer, multiple liver metastases that are very nicely delineated, a bone metastasis in the spine you can see behind the heart. And maybe most impressively, the tumor in the brain. Brain tumors, when they're treated, it's very hard to tell if it's radionecrosis that's remaining or viable tumor. And PET imaging in the brain is not very good because, there's lots of glucose uptake with FDG PET. Here with a DLL3 PET, you can very clearly define that this is a viable tumor. This is a tumor that's expressing DLL3 in the brain. This is not radionecrosis. This is viable tumor. And on the right, this is actually a patient with neuroendocrine prostate cancer. So prostate cancer, like lung adenocarcinoma, can transform into a high-grade neuroendocrine tumor resembling small cell lung cancer. PSMA PET is used for prostate adenocarcinoma. You can see this patient's prostate cancer has gone completely cold on PSMA PET, but all of the bone lesions are lighting up with the DLL3 PET. So we actually think this is a useful diagnostic for patients with small cell lung cancer, for patients at risk of transformation to small cell, and a potentially useful imaging agent generally for high-grade neuroendocrine tumors. You can swap out the zirconium that we use for PET with lutetium, which is a high-energy beta emitter for therapy. And these are data from two of our grad students comparing activity of Rova-T on the left to radiotherapeutic. Again, we cure nearly half of the patients now with limited stage with chemoradiotherapy. We don't cure anybody with chemo. Very radiosensitive tumor. If you can deliver radiation effectively in the context of advanced disease, you can flatline small cell lung cancer. And we're very interested in bringing this forward. We've also labeled it with actinium. You can use an alpha inhibitor, also super effective. We've homegrown a set of antibodies, DLL3 antibodies, that we think are actually superior to what is available in pharmaceutical industry, and we've modified these for rapid tumor delivery. You can see with our lead molecule here, within 24 hours, this is in a mouse model, we get really tight tumor delivery of this antibody with very little background in the rest of the mouse. The biodistribution for this looks really quite promising, and we are bringing this forward. If we compare our antibody to the antibody that was used for Rova-T with the equivalent biolabeling, it's superior. And at the bottom, you can see survival in 100% of the mice with both small cell, cell line and small cell PDX in vivo. And finally, I think a strategy that we're interested in and that is just emerging is CAR T-cell therapies directed against DLL3. Drug companies have been exploring this as well. A grad student in my lab, Janneke Jaspers, had explored this with antibodies that we, again, obtained from AbbVie. She was able to show that an IL-18 secreting CAR T-cell was maximally effective at suppressing and durably suppressing small cell lung cancer in mouse models. And Tony Danyan, who's a clinical member of our cell therapies program as well as a laboratory researcher, has taken one of our homegrown anti-DLL3 antibodies and built a CAR, IL-18 secreting CAR, equally effective. And this is actually now in the IRB. Clinical trial will open in 2026 with this CAR at MSK, and we're very excited about this as a novel therapeutic strategy. We'll see if it holds up. There's been a lot of failure with CAR-Ts in solid tumors, but I think with appropriate armoring with IL-18 and other factors like that, this is, I think, an equally promising approach. So what does the future look like for patients with small cell lung cancer? And I don't know, you don't know, we'll see. But, you know, if we look back, not very long ago, you know, when Julie and I were working together, this was sort of the paradigm. We had platinum etoposide, we had topotecan, and we had hospice. That was it. Everybody died, and there was essentially no new drugs in a very, very long time. What do we have now? I would say it looks more like this right now. We have maybe carbo-etoposide with a checkpoint inhibitor, first-line therapy, and then maintenance checkpoint inhibitor with or without the addition of lurbinectedin. It is approved in this indication. I would argue maybe it should go later. Second line clearly, I think, is established as tarlatamab, in my mind, superior to any of the chemotherapy agents that it was compared to. And then later line, we have the other cytotoxics and the host of drugs that we have in the NCCN guidelines, none of which are particularly effective. Where's the field going? Well, those antibody drug conjugates look better than chemotherapy. They have higher response rates than chemo for recurrent disease. So could they have a role in first line? Could they replace first line therapy? I think they have a shot at that. So I'm laying out this as sort of a future. This is where I would like to see it go. Antibody drug conjugate, one of the several agents that's looking really active in this space, whether it's the Zylab anti-DLL3, whether it's the AbbVie anti-SEZ6, whether it's IDXD, I don't know. But an antibody drug conjugate partnered with immune checkpoint blockade, maybe with a T-cell engager, given the data that we've just seen with tarlatamab, it might be a new triple for first-line therapy, maintenance, immunotherapy, and now, you know, I think there's clear data emerging with tarlatamab, although it could be any of the T-cell engagers together with immune checkpoint blockade. Looks really hot to me in maintenance. I put the epigenetic drugs that our lab is really interested in and that we're doing clinical trials in this space. I have no idea whether they'll work or not. Of course, platinum etoposide is still an active regimen. We'll still have platinum etoposide, and it's still a really important part of the regimen. I put it in the third line space. And then beyond that, there's just a host of really interesting drugs. There are multiple antibody drug conjugates with different cell surface targets, and so there's opportunity for any one of these to move up in the spectrum of, in the sort of journey, patient journey, first, second, third line. So antibody drug conjugate number 2, T-cell engager number 2, a different target perhaps. Lurbinectedin, active agent, a good drug. CAR T-cells, I think, could play a role, and radioconjugates, I think, definitely have a future in this disease. How this is all going to sort out, I don't know, but I think there's a lot of shots on goal here, and I laid this one out, but you could draw your own.